Good afternoon. Our apologies for delay. We've experienced some technical difficulties. My name is Bob Eberlein, and I am from the System Dynamics Society. I'm a member of the OASIS XMile Committee, and we are welcome to the second webinar in the series on Big Data, System Dynamics, and XMile. So we're in this series presenting a breadth of applications showing the power of system dynamics and also the value of a standard for capturing the work that has been done in the field. The first of the webinars was on climate change. It was well received, and we'd like to thank all of you who are attending today who also attended that webinar. This week we moved from climate change to health. It's obviously a very big topic, and it's much on people's minds, especially now in the U.S. as we're seeing changes on the Obamacare rollout. What we're going to present this week is called ReThink Health. It's an innovative approach to looking at health issues, very much based on a model, a system dynamics model of doing that. And rather than looking at it from the national picture, it's looking at it from the community level, starting from the ground up, if you will. So I'm very pleased to introduce Jack Homer. He's an old friend and is a fellow graduate student at MIT, where we studied system dynamics together. He's a primary model developer on this work. And without further ado, I'd like to turn it over to Jack.
Yes, I'm so sorry for those technical difficulties. So this is Jack Homer, and we've got a good crowd today. Thank you for hanging in there. I'm speaking to you from my office in Voorhees, New Jersey, which is outside of Philadelphia. I'm grateful to the people from IBM, IC Systems, and OASIS for making this series of talks possible, and for inviting me to speak today about system dynamics modeling work I've been involved in for the last few years with the ReThink Health initiative. This initiative is under the Fannie E. Ripple Foundation of New Jersey, whose mission for the past 6 decades has been to improve health and healthcare in New Jersey and all over the country. So I'm the lead modeler on this ReThink Health project, but I'd also like to acknowledge the contributions of Gary Hirsch, Bobby Milstein, John Sturman, Laura Landy, and Elliot Fisher, who've been involved in this project since its inception. All right, so to set the stage for this talk, let's start at the national level, where we all know that in America we have a big problem. And this is a famous chart that shows the developed nations. And on the x-axis, we have health expenditures per capita, and on the y-axis, it's life expectancy. And here we have the U.S. These are recent data with high health expenditures and just mediocre life expectancy. And over here, for example, we have the country of Spain, which has much lower health expenditures and even better life expectancy than we do. Now, the fact is that there is, and everybody says this and knows this, that there's a lot of sort of health disparity in this country that this chart is disguising. So in particular, you have disadvantaged people, socioeconomically disadvantaged people, whose life expectancies are significantly lower than those who are higher on the socioeconomic ladder. But the fact remains that we're all paying too much for health care. And the majority of Americans think that the current system needs fundamental change. So enter the Affordable Care Act, which has been much in the news, and which does good things. It extends health coverage. It actually does some things on the public health side. It encourages some things on the healthcare side. But the fact remains that there's only so much that realistically can and will be done at the national level. I mean, even if we move to a single-payer system, which is sometimes called Medicare for all, we might still have a system that does nothing to discourage a lot of unnecessary treatment, and that does too little about things on the public health, the prevention and public health and safety side of things. So the solution of this problem will require more than can be done at the national level, and this transformation will have to come largely at the local level, where the actual services are delivered and where each community is going to have to decide for itself how best to make progress on multiple issues of healthcare cost and quality and health disparities. So we spoke about socioeconomic differences being significant in the United States, but we also see, if you break it down regionally, that there are disparities as well. So on the left here, we have a map that shows premature death by county. And it's a real patchwork. You can find counties right next to one another, contiguous counties that have dramatically different death rates, premature death rates. And on the right-hand side, sort of similarly, there's a map of cancer care quality by hospital region. So hospital regions are around major hospitals, and again, you see some areas where the quality of cancer care is very good, right next to other hospital regions where the care is not nearly as good. So when you run the numbers on this and sort of compare statistically, it turns out that some of these differences are attributable to things like the weather or socioeconomic differences from county to county, or even things like the concentration of specialty physicians. Some counties will have many more specialists than other counties. But even when you take all those things into account, there's still a lot of this disparity that's unexplained, and that could only be put down to differences in healthcare practices and public health priorities. So that's kind of interesting, and it actually gives us, it means that there's real room for improvement. These things aren't fixed, and if only we constantly, so we know where the problems are, and we know that it's not inevitable that they have these problems. And yet, local leaders who want to do something about this problem are often bewildered by the diversity of issues and opportunities that face them. And given limited resources available, both money resources and human resources, they're not quite sure where to concentrate their efforts. You know, what should they do on the public health side of things with regard to behavior and environments? What should they do on the health care side of things with regard to the supply of providers and the quality of care that they provide? So what's interesting is that springing up all over the country the last few years are these things called local health collaboratives. And here's an example of one. These are health leaders. They represent hospitals and physician groups and employers and patient advocates and insurance companies, and they recognize that theirs is one of the areas that needs improvement, and they're not quite sure what to do. I mean, they could, here's the group from Atlanta, for example, and they could look at some other city and say, let's just do it like they do. Let's copy everything that they do. But there are a couple of problems there, and that is, one is that cities really differ from one another in terms of how they have approached this problem. So exactly which one is your peer community that you should follow, that's hard to know. And then also there's just the problem of how do we get from here to there. I mean, it may be very hard to get to where let's say Minneapolis is in terms of their health system, starting from where Atlanta is. So again, they have to pick and choose. Now here's a group that is very enthusiastic. They say that they want to do nothing less than change the culture of healthcare in Atlanta, and that's really a wonderful thing. It's great that these multiple stakeholders have come together to do something, but what should their priorities be, given that there are these many needs and options and only limited resources? So here's where the ReThink Health initiative comes in, where for the last few years we've been developing tools for local health leaders that are developed with experts, sort of local experts and also national experts, and people who've been thinking about changes that can be made at the local level. And so what the ReThink Health initiative does is to coach these local teams and help them think about their priorities. And really the premier tool in doing this with some of the communities has been the use of this system dynamic simulation model that's the subject of today's webinar. What you see here are some of the logos of the organizations that we've worked with in developing the model and thinking about what kinds of considerations should be in it. So I'm going to show you the model a little bit. It's a rather large model with some thousands of equations, but what we say here is that it's actually a simplified representation of a local health system. And what I'm thinking of here when I say that this model that has a few thousand elements to it as a simplified representation is that it could have been millions of elements. You could have modeled every person in the population. You could have modeled every kind of disease or condition that they could encounter and the pathways from one condition to another. And some models attempt to do that, and they're called microsimulations. But this is not a microsimulation. This is a more typical system dynamics model that thinks about things in categories. And you'll see in just a minute the kinds of categories of population and other things that we've thought about. And that's what allows us to simplify this model down to just a few thousand elements so that it runs on a laptop in just a few seconds, as opposed to running on a supercomputer and taking hours to run, which some of these microsimulations do. And that is a profound difference that allows us to do lots and lots of testing, sensitivity testing to see where the uncertainties matter, and so forth, and that allow you to actually sit in workshops with people like the Archie group in Atlanta to consider what priorities might be best for them. So this is a carefully calibrated model that can be used for testing lots of different scenarios. We have about 24 different kinds of interventions. And the idea is to, by combining interventions in different ways, try to see if you can save lives, lower costs, achieve greater equity, for example, between the disadvantage and the advantage, and boost economic productivity. It's important to note, and you'll see here in this graph that we start in 2000 and go out to the year 2040, but it's important to note that, like other system dynamics models, this is not a forecasting model in the sense that we're trying to tell you exactly where we'll be in the year 2040. There's just too much uncertainty. We know that that is really impossible. Forecasting is basically impossible beyond, let's say, a few years, and this is not that kind of model. This is a model that's meant for policy analysis, which is something different, and which is something that you have to get your head around. It's actually possible with some confidence to draw conclusions about what how you were going to bend the curve or change the outcomes, relatively speaking, when you do some set of initiatives versus some other set of initiatives. And that's what I mean by policy modeling, and that's why we can go out decades and have some confidence that these results are helpful and that they help the local leaders get a sense of where things might be going, sort of look around the corner and not forget about various possibilities. So this model builds on prior models and various data sources. The direct predecessor model is called HealthBound, and that's a model that a group of us developed back at the Centers for Disease Control and Prevention in the late 2000s, dealing with a health system, but dealing with it at a national level. So, for example, we could ask questions about what if you moved to a single-payer system, but it didn't include a lot of the sort of the local flavor that we have in this ReThink Health model. Another predecessor model is called PRISM, which dealt with chronic disease, which is a sort of a central piece of the ReThink Health model because chronic disease is responsible for something like 78% of our healthcare costs. And then we used lots of data sources at the national level, at the local level, lots of acronyms here, but these are very important surveys for our ability to ground the model and then to be able to calibrate it to different local areas. Of course, there's a lot of research literature that helps to fill in the gaps also, and speaking with subject matter experts as well. So I want you to get the idea that we've been working on this for a few years, really trying to ground this model in the best data and evidence that's out there. Part of that process involved speaking to people at a local level so that we understood what their sort of unique concerns were that we weren't getting from sort of the national level experts. And we started this in the year 2011, working with 5 different communities around the country, asking them questions about what interventions would they be considering, what are problems at their level that seem to be the most intractable, and from this phase 1 modeling and then the phase 2 modeling that's more recent, we've developed a model that is really pretty nuanced, has lots of richness to it. We've also developed what we call the Anytown model. This is based on U.S. level data, and then it represents a microcosm of the U.S. It's scaled down by a factor of 1,000, so you end up with a community, a hypothetical community of about 300,000 people, but with all of their sort of prevalences of conditions and so forth, looking very much like the U.S. overall. And this is a model that is popular among sort of national level experts that we do workshops with, and it's also used sometimes with communities when, for whatever reason, they choose not to commission their own calibration for their own area. So, and often when we go into a new area, we'll start with the Anytown model, and then at some point they may decide to commission their own. So every one of these models that we've done for the local case studies you see up here has been translated first into a model using the VenSim software, and then has been ported over to the Foreo Simulate platform, where it is available for online to the community for them to test their strategies. And it's also available to anybody who chooses to go through the ReThink Health website, and you can find all these models right there. It's just a matter of registering. And we'll give that website a little bit later. So before we look at some example simulations, I want to just lift the hood on this model a little bit to give you a sense for what a local health system sort of looks and feels like. We start with a geographical boundary of concern. So this might be a county, or it might be a contiguous set of counties with a major hospital in the center of them. But primarily what we're thinking of here is an area of a population which will be affected by the initiatives that the local group is considering. So it's really an area of intervention. So within this area of intervention, we have a green rectangle that, well, first of all, we have a population that we split out. Again, these are not individuals, but they're categories by age, by socioeconomic status, and by health insurance status. And these things can actually change over time. There's aging of the population. You can have changes over time in the split of the poor and the non-poor, and then the insured and the uninsured. And these things can change systematically, and that's what we are looking at in the model. We also characterize the population in terms of its level of risk, health status, the capacity to deliver care, the quality and quantity of care that's delivered, and the cost of that care. Further outputs include economic productivity in the area and health equity, that is a comparison of health status or other measures of health and illness, comparing the poor and the non-poor. But the whole point here, of course, is to think about how initiatives will affect this whole framework of risk leading to health, leading to care, leading to cost. And we also think about what makes those initiatives possible or what makes them more effective. So, for example, funding is an important concern. And we represent that down here with a few words: innovation funds and captured savings, that we'll talk about in a few minutes. The idea of a payment scheme. Here we're talking about payments to doctors and hospitals. In most cases today, they're paid on a fee-for-service basis, which and another way of paying them is called capitation or global payment, and paying them globally as opposed to fee-for-service may actually motivate them more to cooperate with some of the initiatives that are aimed at them that may involve investments in information technology and so forth. I should also point out that there are some exogenous trends that come into the model, so you can specify how insurance eligibility is changing as a result of the Affordable Care Act, or is there a recession and how quickly will we climb out of it, and so forth. So let's just say a few more words about each of these red concepts. So, and there we go. And I'm going to do this by sort of imagining an individual and how they experience this system. So here's an individual who maybe have certain risk factors associated with unhealthy behaviors. Here we're thinking of bad nutrition or inadequate exercise or alcoholism or smoking or other kind of substance abuse. We also think about environmental hazards and crime and poverty, all of which can affect somebody's tendency toward health problems, either disease or injury. So let's imagine the case of a person who has bad nutrition and is a little bit inactive. They're not exercising enough. And this has led to them becoming obese. What might happen to that person? That person will be more likely than others to develop a chronic illness like diabetes. In the model, we think about physical illness. We distinguish mental illness and the difference between mild and severe, or controlled and uncontrolled illness. So this person may initially have a mild case of diabetes and with some symptoms associated with that. If at this point they get the care that they need, they can be held in that mild state of chronic illness, and they can live a long, healthy life. But if they're not getting good care and they're not taking care of themselves well, they can become sicker and fall into this category of severe illness that makes it much more likely that they'll be utilizing emergency rooms and hospitals and high-cost resources. When we talk about capacity as a bottleneck in the model, we're thinking of primary care, and I think it's pretty well known that there are some shortages of primary care. A lot of people coming out of medical school go straight into a specialty rather than becoming a primary care doc. The financial incentives move them in that way. But if you look at the numbers, the truth is that most people with insurance and the means to pay can find a primary care doctor and can get in at least once or twice a year for a checkup. The people who really suffer, and now let's imagine our person with obesity and diabetes is a disadvantaged person without insurance. They only really have a couple of choices. One is to go to a community health center or a federally qualified health center, which does cater to these people, but this is where we really have a bottleneck in this country of not enough of these community health centers. Another option they have if they can't get an appointment at a community health center is to go to an emergency room for their minor ailments. And this happens all the time in this country, and it's one of the things that drives up healthcare costs. Just a few words on care. What kind of care might this person get? If they're getting good primary care, that would be sort of what we consider chronic care or routine care. But the model also looks at episodic care and urgent care, and where is this care given? It's very important if you want to think about healthcare costs to look at the locus of care, which can be an office or hospital outpatient or inpatient or emergency room or a surgery center, a day lab, or if their situation is a serious one and a persistent one, they may need to go into a nursing facility or a rehab facility or home care or hospice. All of these things are actually named in the model, and their cost implications are played out. So one of the ways that we're able to sort of validate or verify that the model is doing the right kinds of things is by looking at national data. This is using our Anytown model now. So the National Health Expenditures Database tracks every year costs in these different categories, hospital, physician, and so forth. And the model does a very nice job of reproducing the year-to-year changes that we've seen from 2000 to 2010 in these categories. And to finish this tour, let me just tell you a little bit about the intervention options that are available. I mentioned that there are a couple dozen of them, and they're broken out into the categories of risk, care, capacity, cost, and funding. I won't go into all the details, but they really are pretty comprehensive in terms of the kinds of initiatives we've heard about from our national experts and our local clients. And in some cases, you can actually specify an intervention to be targeted only at a certain subgroup. Like if we're doing something about improving behaviors, maybe we want to limit it only to youth or only to seniors. Perhaps that's because of limited funds or something. So we can improve the quality of care and do something about improving capacity and reducing costs. There are lots of different sort of suggestions out there about how that might be done. And all of these things have associated with them assumptions about how effective they are at doing what they're supposed to do and how much they cost and sort of how long it takes for them to kick in. Okay, so now we are ready to look at the simulator. We're not going to go online, but here we have a screenshot of the first thing that you would come to if you went to the Anytown model online. And that is you're asked to select initiatives in these different categories that I described. So here's an initiative called Enable Healthier Behaviors, and we're going to focus on this one. We're going to say, well, let's not target it. Realizing that trying to improve people's health-related behaviors is a big project, we're really going to focus on that and do a great job of it for everybody in our community. So we're going to turn this up to 100%, start in the year 2012, and then we have one more thing to do, which is to say, how are we going to fund this initiative? So we go to the funding screen, where there are a few different things that you can do, but initially we're going to focus on this thing called an innovation fund. This is, imagine, a fund that has been put together by these local health leaders. Maybe it's a single funder, or maybe it's multiple funders, but in any case, they've put together $22 million a year for 5 years. And this represents about 1% of healthcare costs in any town in the year 2010, which we've heard from our local leaders is sort of a reasonable amount of money to do anything serious in a community. And so this is $110 million if you add it up all together. And and in a moment, I'm going to show you the result of simulating the Healthy Behaviors Initiative funded to the tune of $22 million times 5 years. So what actually happens here? Here is one of dozens and dozens of graphs that are made available in the ReThink Health interface. This is called the fraction of the population with high-risk behavior. This is the prevalence of risky behavior in the population. It's aggregated across all of the subgroups by income and age and so forth. And so it starts at about 60%, and what we see in the blue line is the base run where there's been no intervention. And in this base run, there's not much change in many of the metrics. But when we do our initiative, what we see is that the prevalence of risky behavior actually declines for a while through around 2018 or so, and then it gradually rebounds back to where it started over the next couple of decades. So why has this happened? Well, over here on the right, we see another graph, which is program spending, which starts in 2012. This program costs about $20 million a year at first. It is trying to help people kick their bad behavioral habits, and it's also helping to prevent people from falling into bad habits. But because it's about $20 million a year and we had $110 million total, we're out of money by the year 2018. We run out of money, and after that point, people, the initiative is no longer in effect to help people kick their bad habits, and more people start to come in now with bad habits. We're not preventing the way we did, and so eventually we revert back to our starting point. So, I mean, this seems almost too obvious for words. You know, we've run out of money, and that was kind of silly. Why didn't we think of that? Well, unfortunately, this is a pretty common predicament for lots of, especially public health initiatives that are made, where somehow the hope is that this is a balloon that can be burst, and once we burst that balloon, the problem will go away forever. But it really doesn't work that way. If you can think about unhealthy behaviors as like a bathtub with, you know, kicking the bad behaviors going out and new bad behaviors coming in, it will sort of obviously revert to where it started if you stop persisting with the initiative. And there are other kinds of initiatives that need to be sustained: anti-pollution, anti-crime, anti-poverty. If you're supporting people with social services for self-care, these are things that need to be sustained to be successful, and it costs us not just 5 years worth of money, but a sustained effort over the decades. So what can we do here? Here are some ideas. Cut the program effort so we just focus, let's say, on the poor or the young or something. But of course, if you cut the effort, it won't be as effective. But it is something that you can try doing. Find more upfront funding. That may be wishful thinking, because they've tried as hard as they could already. Another approach to funding, let's explore that one. So we're going to go back and do another simulation where we explore this thing called savings capture, which is sort of relatively new to the scene, but it's been discussed and it's been tried. This is not just a pipe dream, but there's a growing literature on this thing called accountable care financing. And what it means is that if you can manage with your initial initiative, you know, by improving people's behavior, there'll be fewer injuries and fewer visits to the emergency room. And if you can actually save money on those people and have worked out a deal with your insurance companies this way, to split those savings, then some money will come back to the community. So the idea is that it's in the interest of both the insurers and in the interest of the community to reduce healthcare costs. And if you can do that relative to some benchmark, let's say the year 2010, then year after year, you as long as you keep saving money, you can get some of that coming back to the community to do good things. For example, continuing to do this healthy behaviors initiative. So that's what we're going to do. We're going to imagine that you can split the cost savings 50-50 with all the insurers, the private insurers and Medicare and Medicaid. And in fact, Medicare and Medicaid already are doing experiments in accountable care, and the jury's still out, but it looks like there's real potential here. Okay, the new line is the green line. Here again we have our same graphs of the prevalence of unhealthy behavior on the left and program spending over here on the right. So let's walk through what happened. The right answer, by the way, is that the prevalence of unhealthy behavior declines initially as quickly as it did before, but then it keeps on going right through 2040. So, you know, initially we have the same amount of money that we had before. We're spending the full 20 million approximately per year that it costs to fund this program. But then we don't run out of money, and the reason is that we have been, even during those first 5 or 6 years, saving some healthcare costs on people who, because they are no longer obese, are not suffering the onset of diabetes, or because they are not, or are not suffering injuries that were costing money. So even in the first few years, we're saving some money. That half of those savings get plowed back in to the community to become available for this same initiative. And in fact, over the ensuing 28 years, we captured $379 million. About $300 million of that is required to keep the initiative going, and we're able to keep the initiative going right up to its full funding level, or the full desired funding, all the way through 2040. And this graph is just showing us how much progress could possibly be made if you didn't run out of money. And in fact, you know, this was sort of the low-hanging fruit at the beginning, but there are still a lot of people who might have fallen into bad habits, whose bad habits we're preventing by sustaining this initiative. And if you looked at other graphs, you would see that as a result of this reduction in unhealthy behavior, total deaths are down a whopping 13%. Healthcare costs are down 7%, which is also pretty considerable. Health inequity has declined by 3%. And economic productivity is up 3%, which is pretty impressive. So, of course, the point is not to just find a single initiative that you like, but to find a whole cluster of initiatives that would allow you to make the most progress that you can in a community. Note that in the previous slide, we had some money left over that could have been spent on other initiatives. And so we've done a certain amount of testing, sort of systematic testing of this model, looking at how it works in different communities. And at this point, we've drawn some sort of tentative conclusions. These seem like pretty safe conclusions from what we've seen so far. There's still some questions we have and still some more work to do. And we're going to be writing up these results in papers. But we can say with pretty good assurance that an optimal package of interventions should have certain things. It should have sustainable financing, as we've just seen, for example, using savings capture. It should have cost and care initiatives so that you can very quickly reduce costs and improve the quality of care. But you should also have what we call the risk initiatives, like this behavioral one, whose effects are not just short-term, but are felt for decades later, and whose impacts grow over time. They may be expensive, but they're also necessary to get the most that you can out of a set of initiatives. And they're also pretty necessary for making progress on equity and economic productivity. The cost and care initiatives by themselves don't do that. You need a global payment scheme rather than fee-for-service. It's not that you can't make progress without it, but it's very helpful if you have it in place. Rather than targeting subgroups, it's best to really find the best initiatives and apply them across the entire population. Cost effectiveness is an important consideration. So when you're comparing different cost initiatives or care initiatives, you should go with the ones that are most cost effective to avoid spreading limited funds too thinly. And finally, we do find in comparing the Atlanta model to the New Jersey model or to the Whatcom Washington State model that some particulars of place are important. So, for example, if a community has a disproportionately high level of environmental hazards, then that may be, fighting environmental hazards may be something that you do in that community that's important for that place, but not in other places. So, in other words, place does matter to some extent. And I think I'll just leave those insights there, and you can ask other questions about what we found. But for more information, you should go to rethinkhealth.org, where you'll find a couple of papers that we've written already, and you'll find access points to run the models yourself. And with that, I will give it back to Karim.
Great, thank you very much, Jack. That was a great presentation. I will very quickly go through some slides that we have here on XSmile so that we can finish within 5 minutes or so when we plan to end. And then we'll take some questions. There are a few questions that have come in. So first of all, what is XSmile? This series is sponsored by the XSmile Technical Committee at OASIS. It is a file format that allows us to share models between different tools that do system dynamics. So at the top we have 2 different packages that have the same representation of part of a healthcare model, and they can't communicate with each other. But with XSmile, we use this common XML encoding to make them give us the same model that simulates the same way. It allows specialized one-off models to be transportable, shared, reused, which is one of the key benefits of XSmile, is that we can share models between people more readily. We can also archive models so people can use them for learning, and and for teaching. It also allows us to reuse common components. For example, we can have several components put together into one larger model, and those components can come from people who use different vendors' products initially. It allows open development of add-on tools, for example, analytic-type tools such as optimization. It makes system dynamics more accessible to more people because it is easier for people to adopt when there's a standard. And it also integrates with big data and business applications, enterprise applications. There are also some business benefits. If you're one who actually builds models, you can generate more revenue from those models by using them in new applications. You can increase your productivity by being able to reuse models and their components, which reduces your cost to develop these models, and that increases your profit. The XSmile Technical Committee, as I said before, is part of OASIS. The link is at the bottom if you want to join us. We'd love to have you join us. There are a couple of things in the middle of the page that I won't go through right now that we're talking about right now in the committee, which are different than what we were talking about last time, but please join us. And we will move to questions. My first question is actually back to Jack. I was wondering if you could talk to us about how you think XSmile might have helped your development or helped the promotion of your model.
Yes, Karim, that's a question we've been thinking about. I think we at ReThink Health are really supportive of this XMile initiative and would like to be a part of it. With the ReThink Health model, we're dealing with a big model that has lots of updates and lots of local calibration, and it's based on lots of data. And then it gets ported over to this complicated user interface. So my hope is that XMile could help us manage this whole process more easily, more conveniently. You know, make it easier to update the models, make it easier to bring data into play, and make it easier to translate the model into a user-friendly interface. So I don't know whether all these things are on the table, but that's where I hope it's going.
Great, thank you, Jack. We have a few questions here. The first one is that slide 10 assumes that within a given geography, everything is the same. Can the model handle spatial differentiation? For example, different neighborhoods.
Right, I don't know. This is slide 10. Well, the model is broken out in many ways, but it's not broken out by neighborhood. Okay, show my screen, yes. All right, so again, you know, we have all of these different kinds of segmentations of the population, but neighborhood is not one of them. I mean, in many cases, socioeconomic status is well correlated with neighborhoods, so it can be a proxy in some cases. It's not the same thing, and but this is not a model where, for example, you could ask questions about where is the produce market located relative to a particular individual. It's just it's not broken out that way. You could do that in one of these micro simulations that I described, but not here. And you know, we've tried to strike a balance in terms of how we segment the population.
Great. Here's another question. If risk factors are increasing over time, for example, large and growing population of pre-diabetes, doesn't the amount of savings capture need to be at least at some minimal level to generate any kind of continuing improvement in health outcomes?
Right, very good question. Wow. So in fact, in the model, we do see. I mean, I haven't shown you all these graphs, but there is some gradual increase, which reflects history in, for example, the prevalence of prediabetes. Yes, for sure. The way we think about interventions is that they have to be scaled to the number of recipients, or potential recipients, the number of people who need the intervention. So if you're intervening on top of a growing problem, then it's possible that your funding will have to be sustained at a higher level than otherwise would be the case.
Great, thank you. Splitting health insurance status into insured and uninsured is an oversimplification of the many variables that impact access. Benefits vary across insurers, and specific insurance products vary in terms of covered services and patient costs. How does this model control for these differences?
Yeah, that's an excellent question. And in particular, we've been discussing the idea of including another factor, which we did have in the health-bound model, which is the fraction of costs that are paid out of pocket. So when you look at these plans, it really comes down to, aside from the fact, are you insured or not, when you think about the co-pays and the deductibles and the co-insurance, you know, it really comes down to what fraction of the total cost has to come out of your pocket. So that's a number that is a very interesting one, because depending on whether you look at Medicare or Medicaid or private insurance, it's been changing in different directions. Overall, it actually hasn't changed very much in the last 10 years. But still, there could be differences by age or by type of insurance where that makes a difference. And yeah, we've thought about how we might want to build that in, even though it would still be exogenous. Realize that this is not so much a model about how local insurers craft their plans or how national health insurance plans are crafted. But we may still want to build that in addition to this distinction between insured and uninsured.
Thank you, Jack. Why, if resources are limited, is it best to apply initiatives broadly across entire populations?
Right, another very good question. So if we think about this Healthy Behaviors Initiative, for example, why is it not best to just focus it on the disadvantaged and or on the young? And I mean, really the answer to that is that although the cost effectiveness may be somewhat higher in certain subgroups, if it's the sort, I mean, what we have found is if it's the sort of intervention that has good cost effectiveness, then there will probably be enough people in all of the different segments who should be getting it. And you would actually be doing something suboptimal by looking elsewhere. You should be focusing on those initiatives that are the most cost-effective overall and apply them broadly. There's a whole literature on this that goes back decades about, you know, should you try to squeeze the distribution or move the entire distribution. It's a fascinating literature, and the answer is sort of it depends. But in our model, we find that in very many cases, moving the entire distribution is the thing you want to try to do.
Thank you, Jack. Another question: does the model decompose the components and drivers of unhealthy behavior so there's some guidance as to where the most impact can be made?
Yeah, thank you for that question. We talk a lot about what we mean by unhealthy behaviors, and the question may be getting at, have we disaggregated them, or to what extent, for example, does poverty impact unhealthy behavior, or other risk factors? You know, so let me just say that for now in the model, we've named some risk factors that act differently. This is sort of a system dynamics principle. We've lumped together things that seem similar together and similar in terms of how they impact health. So, and we've split out some things like crime or like environmental hazards that have more to do with injury and less to do with chronic disease. We could split out further, for example, things that, let's say, unsafe sex that would lead to certain kinds of infectious disease. But this again is a balancing act. If we split things out too much, we lose the ability to keep this model compact and one that can run in just a few seconds on a laptop.
Great. One final question: have the model insights been captured by any other type of research method? Can those insights be only generated by SD models?
Well, I think the answer obviously is no. But what we have here is a tool that can address a breadth of issues, and in combination in a way that I haven't seen other tools do. So what I have in mind are some other simulations out there by the likes of the Rand Institute or Jonathan Gruber at MIT, who consults to the Obama administration, and the Lewin Group. They have healthcare simulators, but they're really very much focused on health insurance and in some cases, on health status and utilization of care. But they're typically health care models rather than having the whole public health component that we have in ours. They also typically don't think about long-term feedback loops, like the idea that if healthcare costs are rising and that causes employers to drop insurance for some of their people, and that will in turn affect the health of those people, or if you lose your insurance, then you may become highly indebted and may actually fall into poverty. These are things that we've actually been able to calibrate and put into our model that I haven't seen in any other models. So it's a way of thinking about, sort of trading off, going for breadth rather than great detail. So our model, again, doesn't tell you about all the different kinds of health plans, but it can tell you about how this whole story ties together over a period of decades and not just a few years.
Fabulous. Thank you, Jack.
Thank you so much, Jack, for that wonderful talk. And I'd like to thank all of the attendees for listening in on this, the second in our series. The Slides that are shown, as well as a link for a recording of this session, will be available. There will be links on xmile.systemdynamics.org showing on your screen right now. The YouTubes will also be on the XMile TC channel. And if you want to know more about Jack Homer, he's got a link up here, more about the ReThink Health project. There is a link to that here. Our next webinar will be on credit card market simulation, quantifying the impact of change leads to dramatic strategic innovation, and that's going to be looking actually at a fairly large model that was done to understand what's happening with the credit card and really change the performance of that company. So that will be presented by David Starr and Sharon Ells, and that will be on November 19th, again at 12 o'clock noon, although in the United States it's going to be Eastern Standard Time, so that our clocks are changing, and we hope to see you then. Thank you very much, and good night.